It is time for our weekly visit with Dr. Kevin Kavanagh. Dr. Kavanagh is a retired EMT from Somerset and is the founder of a group called Health Watch USA. Good morning, Kevin.
Oh, good morning, sir.
What is Health Watch USA?
Well, it's a nonprofit organization whose primary mission is transparency of health care. In other words, to know what the costs are and the quality of the care that you're getting, and also a patient advocacy organization. We do a lot in healthcare education and have a yearly conference. This year our conference is scheduled for November 7th, and hopefully people will have some time to come out to that.
We have a special guest this morning, and you've been outdoing yourself here of late with these guests that you have lined up. We've got another good one. Tell us about it.
Well, the guest today is Peter Eisler. He is a really renowned medical reporter, investigative reporter from USA Today, and has done a number of feature stories involving Kentucky. One last year was the article on MRSA, which was one of the impetuses behind our new healthcare regulation, which the governor is currently writing. And a more recent article, which we're going to discuss about today, has to do with narcotic and prescription drug abuse in the elderly. And this just isn't the elderly's problem, because these are prescription drugs, and you can't take a prescription drug without, of course, having a prescription written by a professional. So there are problems in this system. In Kentucky, this is a huge problem. We have the third highest number of overdoses due to narcotics
in the country.
In the country, yeah. We have 7,000 to 8,000, for example, newborns, which are born addicted every year, which is a huge number. And even though these drugs may be obtained on the street, in Kentucky, the vast majority of street drugs actually originate from prescriptions. And in the set of individuals that are very high in getting these prescriptions, unfortunately, the elderly, which not only can be a conduit to going onto the street, but also can impact the elderly themselves with problems with, thinking, cognition, let alone respiratory depression and even death. And so this is a huge problem. And I'd like to, at this time, get some comments from Mr. Eisler.
Peter, good morning.
Good morning. Hi, thanks for having me on.
Hey, listen, thank you very much for taking time to be with us this morning. We truly do appreciate it. And I'm sure you will back up what Kevin just said about our very negative statistics that we have in Kentucky.
Yeah, and what you're seeing in Kentucky is really part and parcel of what's going around the country. I mean, we looked, as Kevin mentioned, we looked very specifically at seniors, people 65 and older, and how they were faring in what the CDC, the Centers for Disease Control, have labeled an epidemic of prescription drug abuse nationwide. So, if you look at seniors, the data that we reviewed for our story, some of it from the federal government, suggested that there are, well upwards of 300,000 seniors in a given year who are misusing or dependent on prescription drugs, and by and large, the drugs that are involved are painkillers, narcotic painkillers, things like oxycodone, hydrocodone, and also these psychoactive anti-anxiety drugs, drugs that would, commonly be known, for example, as, Xanax or Ativan, things like that. So these are the classes of drugs where we're seeing the biggest problems, and we've seen, a sharp increase, more than 50% increase in emergency room visits for seniors related to misuse of prescription drugs. We've seen a similar increase in the rate of drug treatment program admissions for seniors who are grappling with problems with these drugs. So it really is a problem that's having significant consequences.
Are these drugs, the ones specifically that you mentioned, if you have chronic pain and you're on them for an extended period of time, is it true that you will be addicted to them at some point?
There certainly is a very, very high risk of dependence with many of these drugs over a long period of time. And, it's interesting, the thinking in the medical community has really evolved fairly dramatically over the past several years on this, to the point where now most of the, sort of the established medical groups are suggesting that physicians be extremely cautious about using these drugs for long-term treatment. They can be very effective for short-term pain. You come out of the hospital, you've had a hip replacement, or you've had some sort of surgery. They will give you a painkiller to recover from sort of the immediate pain of the surgery. What's a much bigger risk is when you see people who are taking these drugs long-term for chronic pain, for arthritis or for lower back pain. And many of the new studies suggest that not only is there a lot of risk to being on these drugs for a long period of time, but also they don't do much good after maybe a month or two at the most. You start to see diminished returns, and you have to start taking more and more to get the same result. And eventually you sort of become a zombie.
And so that's when it really becomes a problem, when you need more than the doc's writing you for.
Yeah, well, yes, certainly that is certainly a cause for concern. But also, a lot of the time, one of the problems and one of the things that public policy folks, the healthcare policy folks, are trying to get out there is to inform even physicians who often are sort of not plugged into the new way of thinking on this, who might think it's not a problem to continue to escalate somebody's dose over time and to leave them on these drugs in perpetuity. It's not just on the patients, as Kevin mentioned.
And we've got these places that are so-called pain management clinics. How do they figure into this equation?
Well, I suppose like any business, you've got good ones and you've got bad ones. There's nothing wrong with a pain management clinic on its face. We have a huge number of people in this country that are dealing with chronic pain, and it's a very significant health issue. And there are physicians who specialize in this, and they have all sorts of treatment approaches. And, a lot of these clinics will have, physical therapy components to them and other sorts of approaches to pain management long term. And then also, physicians who may prescribe certain types of painkillers, in some cases even over extended periods, but those patients would be very closely monitored. On the other hand, you also have pain clinics, and I would put that in quotes, that have gotten in a lot of trouble for being what are sort of euphemistically called pill mills. When something is a pain clinic, it's all about, how good that place is. You have to take a close look.
Yeah, and I think that's a really an important point, is that the management of chronic pain, really narcotics has to take a back seat to many other types of options. And there are some people that think, and I'm included, that narcotics just don't treat chronic pain. You essentially get addicted to them over the course of weeks or months. Your body adapts to metabolizing the drug, and your receptors to the drug become more resistant to it, and it gets to the point where they just don't work, and your pain threshold lowers, so that many times the people I see are probably in more pain months after being put on these things than they would have been if they would have been off of them and on other forms of treatment, such as anti-inflammatory agents or physical therapy.
It hasn't been too many years ago that you could go and have some sort of simple procedure at the dentist's office, and he's going to send you away with a script for Lortabs or something like that. But they don't do that anymore. The government has really clamped down on this, and aren't doctors afraid to write these prescriptions these days?
Well, I think for non-surgical pain, if you're post-surgery, you need to have a few pills. Now, you don't need to have 90 pills. A good friend of mine had bilateral total knees and didn't take any pain medicine. My last back surgery, which was a 2-level fusion, along with it, redoing some other levels, I think I had 1 dose of a narcotic. That was it. One pill, and that was at night. I wouldn't even have taken that if it wasn't given to me, because your body will build up endorphins, or a natural way of fighting pain. And they do work, but it takes a while to get that build up. Now, it does make you tired. I'll tell you, when you get, when you would normally have pain, instead you get kind of a mild discomfort. Fatigue. You get very tired and fatigued. But it's better than being addicted out on opioids and essentially a zombie.
What's happened in our state, Peter, and it probably has in other states as well, is we've done a pretty good job in Kentucky of clamping down on this illegal prescription medication, and so now heroin has reared its ugly head, and since these folks who are addicted to that stuff are having more and more difficult time to getting the prescription drugs, they're going back to heroin.
Yeah, I mean, that is something definitely, and again, you know, what you're seeing there in Kentucky is no different than what they're seeing in a lot of parts of the country. And you were right. You had noted that there are more, you know, there certainly has been an effort at the federal level and at the state level in many states to sort of crack down on overprescribing of these drugs. And you had mentioned doctors being afraid to write these prescriptions.
Yeah.
You know, you hear about that anecdotally, and you may run into some physicians who, if not afraid, are certainly being more cautious about it. You know, whether they're, I think it's probably in many cases less them being afraid of getting in trouble than it is just that they're sort of getting the message that you have to be much more cautious and judicious in the way that you use and prescribe these drugs. On the other hand, if you look at the numbers nationally, the numbers of prescriptions being written for these drugs continues to increase at a very substantial rate. So there's no data to support the notion that, you know, the medical community as a whole is become more reluctant to write these prescriptions. I think there are certainly physicians for whom that is true, but overall, on the whole, you know, these numbers are just continuing to go up and up and up.
Peter Eisler is an investigative medical reporter with USA Today. Of course, we've got our physician in residence here, Dr. Kevin Kavanagh, with us, as we do once a month. And Dan Smoot is going to jump in here now from London, Kentucky. He is the CEO of Operation Unite. Hey, Dan.
Hey, Jack. How are you?
I'm doing well. Dan, what is Operation Unite, sir?
Well, we're trying to address the drug epidemic in southern and eastern Kentucky, and I want to start out by thanking you and Kevin for addressing this very important problem. It's rarely discussed, and it is a huge problem here in our district. And, you know, Peter was exactly right. We need more prescriber education. I'm afraid our prescribers, although they're well-intentioned, I just don't think they have enough experience and training in the field of addiction.
By the way, Peter, you're live with us, too. You're in on this, and so you feel free to interact whenever you'd like.
Okay, great. Thank you.
It's an even bigger problem the more you go to the east, right, in our state?
Yes. We see a lot of it in eastern Kentucky. And, you know, there's additional problems that come with it. We see so much theft and burglary and robbery.
Oh, yeah.
And even some of these people, as you know from the news, are they're actually murdered for their pills. And, you know, a lot of the addicts know that senior citizens receive a lot of narcotics, and therefore it makes them a target of theft and burglary and robbery.
Peter?
Well, yeah, I mean, certainly there are all sorts of, you know, it's when they try to calculate the toll of the prescription drug problem across the population, there are all sorts of things that they have to account for, and, you know, certainly, you know, some of the crime that's associated with people trying to get these drugs and steal these drugs is a problem, and, you know, people think of the consequences of, you know, misuse or abuse or dependence on prescription painkillers, for example, as being an overdose. But there are actually many, many other health consequences as well. For example, with older people, you know, which were what we were writing about, the number of falls goes up exponentially. So, you know, what happens is you get a senior, they get on some of these drugs, the doses escalate over time, they get a little wobbly on their feet, they get a little bit disoriented maybe, they fall down, they break a hip, they end up in the hospital. You know, someone who's 75 years old goes into a hospital with a broken hip, there are all sorts of other risks. They can get pneumonia and die. And, you know, so when they're trying to calculate out the toll, it's very difficult to sort of give people the whole picture of what the consequences of these of this drug problem are. But they range from crime to all sorts of health issues that might not sort of immediately be evident.
Kevin, what are we doing in Kentucky legislatively to control this?
Well, you know, we had passage approximately 2 years ago of House Bill 1, which not only was a mandatory reporting bill, but put in a number of guidelines requiring a full physical examination and monitoring with urine tests, etc., of patients, you know, taking the drugs. And this has resulted in some dropping in the rates in Kentucky. And one of the things I was very pleased to see was that as I was preparing for this show, I found a organization called Oklahoma Watch, which was actually using what was done in Kentucky as an example for the Oklahoma legislature to try to implement implement changes in that state. And so in that sense, we are sort of leading the way. But it is a huge problem because I cannot underscore, I've practiced in this area, and you just can't overstate the difficulty it is for physicians in this area. Yes, there are, some physicians that are writing out prescriptions right and left that is absolutely inappropriate, but believe me, there are many others that are seeing these patients, and these patients put you under a tremendous amount of pressure in order to get their medications. As I can recall, there was even one physician that got killed in Kentucky over not prescribing these medications.
I'd forgotten about that. You're right.
And there's also a lot of deception that will go on to the point where the patients will sometimes even self-mutilate themselves trying to get pain medicines. I remember a case that an ER doctor was telling me, and this was in my local area, where a gentleman had made an incision on his leg similar to a total knee incision, put stitches in it, and then went into the ER. Of course, it wasn't a very good job. This is how they figured it out.
Right.
Trying to get medication post-op.
Wow.
And so you see these type of activities. So it is a very difficult, it's a very difficult situation. And when you see this and you see the difficulty it is to get these patients off these medications, you understand why they're illegal. I mean, it's incredible.
I have a friend in eastern Kentucky who is a dentist, and he says he will regularly get people coming in wanting him to remove completely healthy teeth just for a prescription for pain meds. And we're back. Dr. Kevin Kavanagh in the studio with us, and our special guest this morning is Peter Eisler. He's an investigative medical reporter with USA Today. Dan Smoot's on the line. He is the CEO of Operation Unite, and we had a caller, gentleman, who did not want to go on the air with us, but she said, and this is a great question, caller has a sister currently addicted to painkillers. The more she takes, the less effective they become, as we've already talked about. What is the first step to take to help her? That's a great question. What do people who have friends and loved ones who are addicted to painkillers do?
Well, Jack, as far as Eastern Kentucky goes, Operation Unite has got one of the only voucher programs in the United States. If someone is addicted and is wanting treatment, they can call the Operation Unite, and we pay for long-term inpatient treatment if you live in the 5th Congressional District.
Can you give that number?
1-866-90-UNITE, UNITE.
And Peter, I think, if I read it correctly, that in your article that you did on this subject, something like 1 in 4 people over age 55 are on some kind of painkiller?
Well, they're on, some sort of what they call psychotropic medicine. So that's medicines that affect the brain in a certain way, but that would include all narcotic painkillers, and it would also include a lot of these anti-anxiety medications that we've talked about, which also are can be very addictive, induce a lot of dependence, and also are not recommended for long-term treatment. And those numbers also have been going way, way up.
Here's an email that says, Amen. I had gallbladder surgery December of 2012. The surgeon prescribed 20 oxycodone. I have doctor and dentist friends who are in AA who said that there should never be more than 5 or 6 oxycodone prescribed. I turned the whole batch in at the last collection by our local firefighters. Either one of you guys have a comment for that?
Well, Jack, I have one. The last part, she turned it in. The proper storage and disposing of unused and unwanted medications is so vital. Operation Unite and other agencies, and you can go on operationunite.org and see all over the state where there's drop-off locations. But here in eastern Kentucky, most all sheriffs and police departments have drop-off sites for unused and unwanted medications.
And I think the number one point to make here this morning, and we've made it, but I think we need to underscore it, Peter, is narcotics do not treat chronic pain.
Well, it certainly it would be under very limited circumstances. I mean, there are, it's pretty widely accepted that for certain types of cancers and for end-of-life care, people who are terminally ill, long-term treatment with narcotics is more accepted, but you're absolutely right. For chronic pain, commonly you'll see back pain and osteoarthritis pain. Long-term treatment with narcotics is generally not regarded anymore as effective or particularly safe.
Yeah, and that's true. I mean, I've had multiple back operations over 20 years, and you'd need to stay off of those things. And I can remember being at a conference in Lexington where the doctors were talking about using narcotics and how you manage chronic pain with narcotics, and the two doctors in the room, myself being one and another physician who was obviously had been severely injured in a traumatic accident before that was multiple arthritis. We were the two that were not on the narcotic pain medication regime, and spoke out and said this isn't effective. And when you say long term, you're not talking about years. You're talking about weeks or months where you get into trouble with these things, and so you have to be very very cautious. And as pointed out in Peter's USA Today article, that doctors are prescribing these more and more in record numbers. And you can look at it from the aspect that patients are taking them, but doctors are prescribing them. That's why they have a license, and you have to get a prescription because they're supposed to be the entity that says no, this isn't needed, or we're not going to give that. And as I said, that can be hard to do because addicted patients can become violent, and so you got to be very careful.
And there was a big piece in the Lexington paper, I remember a couple of years ago, about the pipeline to Florida and how there were lots of Eastern, or just Kentuckians, not necessarily Eastern Kentuckians, but Kentuckians that were going to these clinics in Florida and getting the pain meds. Haven't we pretty effectively shut that down, or have we?
Yes. Well, I say yes. I think we've made great strides between federal enforcement and then state laws in states such as Georgia and Kentucky. I think we've come a long way. But earlier I heard you said that then comes heroin.
Yeah.
So the bottom line is, it's not that if we stop one drug, what we see is a replacement. And I think that's why we need to do a better job of educating the youth, and we need to spend more money on long-term treatment options here in Kentucky.
Well, that's a good point. That's a good point. Peter, you agree, I'm sure.
Yeah, I mean, I don't know the situation specifically enough in Kentucky to say, but as in many of the things that we've discussed, it is a microcosm of what's happening across the country, and certainly there are many people who believe that better education for prescribers, on addiction and on sort of the risks associated with long-term prescribing of these drugs is important. Education of consumers, of patients, so that they know what to do, and all of that stuff. Nothing comes for free. So. 253-5959, touch star 590 from AT&T, toll free from anywhere, 1-877-777-0590. Or email jackpatty@wvlkam.com. And this House Bill 1 that you were talking about is what really was done very effectively and caused the heroin to come back. If you're addicted, you're addicted, and if you can't get it from source A, source B might just be as good.
Well, people will say that, but I think you have to look at really the magnitude of the problems. Getting heroin, I would bet, is a lot more difficult than strolling down to your local doctor and coming up with a story and getting more pain medicine.
Right.
So I think it's going to cut down on the number of, on what's being used. And also I think that there's overall a feeling, especially among the youth, that, if it's prescribed by a doctor, this is safe.
It's got to be okay.
As most people know that heroin is not.
Right. Bob, good morning. You're on the air.
Good morning. How are you today?
Well, thanks.
Interestingly enough, I'm listening to your discussion, and it seems that the medical field as well as the general public think that anyone that uses or has to use pain medications to survive and to be mobile is automatically addicted.
And that's not true. I'm glad you say that, because that's not true.
right, it's not true. There's a difference between dependency and addiction.
Right.
You know, I take medication for my heart. I'm not addicted to it.
Yep.
However, I am dependent on it.
Yes.
Yeah. I'm on Percocet for my back. I broke my back, fell off the roof a year ago. Broke my back in 2 places, and I've got severe scoliosis in my back from osteoarthritis. I'm only 71. Now, why should I be committed to have to stay home and not be active rather than have some pain medication and still be active?
Bob, I'm so glad you called. You stay on the line. Let's start with Pete. Pete, what do you say?
Well, you know, I think he makes some excellent points. There is certainly a strong and important distinction to be made between addiction and dependence, and you know, there are things that have to do with, you know, drug-seeking behaviors and whether you're altering your life to get these drugs. And there certainly is, as I've tried to suggest, there certainly is a legitimate role for narcotic pain relievers in treating pain. You know, if it's a situation where someone has an injury and, you know, they have these pills around and they take them once in a while if they've had a particularly active day to relieve the pain, you know, that's a different kind of scenario than someone who is taking multiple pills every day over a long period of time, months and months and months. At the very least, a physical dependence is going to develop, and sort of the emerging consensus in the medical community is that in many cases that physical dependence is not something that is good or that is beneficial. And when people start to get to that level of consumption, they're not really getting much benefit from the drugs anymore. You start to get into escalation of doses and that kind of thing, and that's where you really start to get into trouble.
Dan Smoot, what do you say to this caller?
Peter's exactly right. He touched on every subject there. And I don't think Bob's the typical patient we're talking about.
Right.
You know, the ones that everybody, we don't want to see anybody in pain, of course. And,
right.
You know, and there's such a need for narcotics in certain instances. And I think Bob's one of those cases, but he's not the case that we see.
That you see, right. Bob, does that help?
Well, yes, and I'm in full understanding of that, but it kind of irritates me that the media, as well as healthcare professionals, say, well, you know, we're just not going to give you pain medication. You can lay at home and, you know, just die.
Just lay in the bed.
Well,
yeah.
let me jump in here real quick. This is something that really patients have to be motivated to do. If you take a drug, your body's going to respond to it, and you're going to get dependent. I mean, that's a biochemical thing. You can't get around that. And studies have shown that if you compare 2 sets of people, one on drugs of chronic pain, one without drugs and chronic pain, there's not that much difference between the two.
Dr. Kevin Kavanagh in the studio with us, and on the phone with us this morning is Peter Eisler. He's a USA Today investigative medical reporter. Dan Smoot is the CEO of Operation Unite here in Kentucky, and the lines have lit up here toward the end of the show, so let's go to the phones. This is Steve. Good morning, Steve.
Good morning, Jack, and good morning to your panel.
Good morning.
Hey, I just wanted to say that your previous caller makes a very good point. I myself was injured on a construction site several years ago, and you know, I've always taken all of my medications just as they're to be taken, never had any problem. But you know, I've experienced a problem here lately. My pain management doctor, which is the only one that will prescribe these pills, has left and does not practice that anymore. And I'm just kind of cast out to try and get into one of these places, which can take 3 to 4 months, and nobody wants to write these medications for you during that interim time. And I've experienced numerous occasions, as I am today, where I'm running around dealing not just with the pain, but all the side effects of not having these medicines in my systems. And, you know, just like your previous caller, I continue to work and be productive in society because, you know, he was 71, and congrats to him. for doing so. You know, I'm in my late 40s and work in the construction field. And, you know, I just think that there's some things that we need to do because there are a lot of people out there that comply with the regulations and are stigmatized by what we've done here recently.
It's a good comment.
I'll hang up and let you comment.
Thank you, Steve. All right. Anybody Pete, you want to go first?
Well, you know, I think that, you know, what we said before is, I think stands. There certainly are instances where it's becoming more difficult to get these drugs. There are doctors who are becoming more careful about writing them. But overall, if you look at the number of prescriptions being written nationally, at least, and I can't speak for Kentucky, and perhaps Kevin can, you know, there has been no letdown in the number of prescriptions that are being written for these medications. In fact, the numbers continue to go up and up and up.
Yeah, and I think to relate that, I think it really puts in perspective that when you look at national statistics and you say something's going awry, it's very difficult to then apply that to individual patients because of the individual stories that they have. But I would say on this last caller that, one, if you're writhing in pain, that's when you need a narcotic. Otherwise, you know, get your body to start pumping out endorphins to try to make, to make it through the day naturally as opposed to taking the narcotics. And if you're on narcotics, I would be very careful working construction jobs. I mean, you know, there are certain things that these medications, even
they
normally,
even say on the bottle, don't have heavy equipment and
everything else,
right.
that's probably not appropriate. And of course, you, as I said, be very, very careful doing that because these narcotics have side effects, and to come off of them, you will go through a withdrawal. I mean, this is a biochemical thing. It's nothing that you know is right or wrong or is up to the person. This is how the body reacts to those
things. Dan.
Well, Jack, I don't think the average caller appreciates the magnitude of the problem. You know, the United States makes up 4% of the world's population, and we consume 98% of all hydrocodone manufactured.
That hammers it home, doesn't it?
And if you look back 40 years ago and you look at the evolution of these painkillers, they just keep getting stronger and more powerful.
Dan, I got to jump in here. I'm out of time. Thanks for being with us, Dan.
Okay, thank you.
And Peter, thank you so much. I know you're a busy guy. Thanks for taking time to be with us this morning.
Thanks for having me. It was a pleasure.
Sure. And thank you, Kevin. We'll see you next month.